All right, we're going to move on. And I think it's a nice segue in discussion of kind of the differential and the overlap of disease states that can cause lower extremity edema. It's my pleasure to introduce Dr. Thomas O'Donnell. He's the Benjamin Andrews Emeritus Professor of Surgery, Chair of Surgery at Tufts University School of Medicine, and has published extensively and has extensive experience on the overlap between venous disease and lymphedema. Dr. O'Donnell, thanks so much for coming.
Thank you very much for inviting me to this symposium. And it's a tremendous assembly of great speakers. And it's nice to come to an event where you learn more than you're going to provide to the audience. I'm going to address secondary lymphedema and focus on the connection with PHLEBOLYMPHEDEMA. These are my disclosures, and I'm going to focus on generic products, devices only. So why is the evaluation of the veins important in secondary lymphedema? Well, we've heard earlier that if you look at known causes of secondary lymphedema, breast cancer is preeminent in the minds of most physicians, and certainly going to lower extremity melanoma or GYN cancers. I think advanced chronic venous insufficiency, CVI, is sort of the hidden and overlooked component to secondary lymphedema, particularly of the lower extremities. So how do we determine the etiology and prevalence of secondary lymphedema, in particular in venous diseases? Well, there are several methods. One is to look at epidemiologic studies. One is to examine proprietary de-identified healthcare claims data, which I'm going to present, and then look at large observational case series. Dr. Dean's series is a good example of that. So here's 4 different epidemiologic studies, one from Derby in England, a Turkish study, a Danish and a Canadian study designated by the color, and I've divided the etiologies into cancer, venous, obesity, and primary. And you can see that cancer and venous sort of reverse at certain centers. In the Derby study, it was very high for cancer as well as in Turkey. But then when you go to venous, it reverses. And so do the Danish and Canadian studies. So it is a predominant cause of secondary lymphedema. Now, we've been doing a lot of work with big data where you, and in this particular instance, determine the proportion of patients with lymphedema in 2 large administrative healthcare claims databases. One is the Blue Health Intelligence with 27,000 or so patients diagnosed with lymphedema. The other is the IBM Market Scan, which has nearly 86,000 patients with lymphedema. Obviously, when you're looking at big data, the patient has to encounter the encounter the physicians and get into the records, so there's a bias there. We looked at patients who were enrolled with continuous medical and pharmacy benefits for 12 months before and after the index date, which is when they were diagnosed with lymphedema. And then we categorize them by their comorbidities known to be associated with lymphedema to identify specific causes. And this is the results of that study. Actually, it was published, one of our vascular fellows wrote it up. And basically what you see in this large population is the #1 cause of lymphedema, secondary lymphedema, is breast cancer, no surprise. But the #2 cause of secondary lymphedema is venous disease, accounting for about 10.4%. And it is the most common cause in the United States of lymphedema of the lower extremities. Pelvic cancers, uterine, ovarian, and cervical account for about 3%. A similar survey, the IBM Market Scan, with about 86,000 patients in the lymphedema population, again showed the 2-to-1 ratio of, I didn't know they allowed beer in here, of breast cancer-related lymphedema to venous lymphedema, but again plays a prominent role in secondary lymphedema. Steve Dean, who spoke earlier, published a very interesting analysis of his 440 patients, a retrospective analysis, where he looked at the demographic and clinical characteristics of near 450 eligible patients with lower extremity lymphedema. What I find unique is these patients were seen at a lymphatic physiotherapy center, which was at a cancer-based physical therapy department. So there would be a bias towards cancer-related lymphedema, you would think. And basically, this summarizes the results. The cause on the left, CVI-VLU, these are in percentages. The single cause, actually CVI-VLU slightly outweighs cancer. Again, we're dealing with lower extremity, primary, and lymphedema. However, when you look at dual causes, and this is a very important point of Dr. Dean's article, is that don't look singly at a cause, look at potential other causes. It was pushed up to 42 when you looked at the cancer and surgical patients, and the cancer patients were pushed up to 34. So it's certainly apparent that CVI, secondary lymphedema, is the most common cause in this population. Now, what about the term PHLEBOLYMPHEDEMA? Well, that really didn't come into being until this textbook in 1998, when Kavisi and Casely Smith, a well-known researcher in lymphedema, coined the phrase, which is chronic venous insufficiency from CEAP classification C3 to C6. CEAP is a vascular venous classification based on clinical findings. CEAP3 is swelling. CEAP6 is an open ulcer, and we'll see what C4 is eventually. So why does a patient develop PHLEBOLYMPHEDEMA? Well, it's related to ambulatory venous hypertension, where there's increased pressure from the insufficient reduction in pressure when you walk, as seen in the capillary bed here. There is venous hypertension that increases the amount of fluid that exudates out of the capillary into the interstitial space. And this leads to increased fluid. What happens next is that the lymphatics compensate by increasing lymph drainage and thereby containing development of edema. What we have to look at now is the revised Starling curve. We used to think that on the venous side, you'd reabsorb fluid. That's not true. Levick-Michel showed that due to the glycocalyx, there's no reabsorption. So any interstitial fluid has to be transported by the lymphatics. And as the disease develops, fluid excess eventually overwhelms the transport capacity of the lymphatic vessels, resulting in persistent swelling, i.e. PHLEBOLYMPHEDEMA. So we spent a lot of time listening to Dr. Dean, and he presented some beautiful pictures. That just shows the state of how we're making the diagnosis of any secondary lymphedema. It's purely clinical for most parts. And it's unlike the standard evaluation disorders of the rest of the circulation, as the Charles Woody said, a great researcher from Arizona in lymphedema. We have to rely on these patients on a clinical diagnosis. And these are typical findings of patients with PHLEBOLYMPHEDEMA. On your left, the pigmentary changes that are seen. You'll notice that there is some mild foot swelling, but sparing the toes. And on your right, there's the classic champagne bottle deformity in the limb seen in patients with PHLEBOLYMPHEDEMA. The pigmentary signs give you a clue that it's venous in origin. I mentioned CEAP clinical classification of advanced venous disease. It's subdivided for patients with CEAP4A, where you have secondary changes in the skin and subcutaneous tissue due to the increased venous hypertension, and then progresses on to, in C5, to a healed ulcer, and then to an open ulcer. So what are the characteristics of patients with PHLEBOLYMPHEDEMA versus other secondary lymphodemas? Well, this compares 8,500 patients from this survey to 17,000 with breast cancer-related lymphedema. And you can see in all these patients, the proportion, the age, the incidence of diabetes, hypertension, heart failure, obesity, they're all much greater than in the breast cancer-related patients because the breast cancer-related patients are probably much healthier. In addition to clinical evaluation, the DUPLEX ultrasound exam plays a major role in evaluating patients with venous disease and in particular patients with PHLEBOLYMPHEDEMA because it confirms venous etiology, what the anatomy is it amenable to some form of intervention to correct venous hypertension? It also can be used to assess the degree of edema. And this just shows on your left a typical finding of assessment in a limb where the patient has involvement in the great saphenous vein. With Valsalva maneuver, the blood goes in reverse direction. And on your right, you see scarring within the deep venous system, indicating previous thrombus event. And these help you establish the diagnosis of venous etiology. In addition to using the venous side, we use clinical classification, the classic ISL, to classify the lymphedema into the 3 stages. Generally, we see patients that have stage 2 or stage 3 PHLEBOLYMPHEDEMA. Now, lymphoscintigraphy fascinates me because I spent my formative year in venous lymphatic with John Kinmouth, who developed the lymphangiogram at St. Thomas's Hospital in London, and with another vascular surgeon by the name of now Sir Norman Browse. Both have passed away, and they used it extensively as lymphoscintigraphy is. So we looked at 50,000 patients with lymphedema in this research database because I was interested how frequently do we use lymphoscintigraphy, at least in this real world. The overall usage was a low 2.5%, and the highest was in breast cancer-related lymphedema. And the patients with PHLEBOLYMPHEDEMA, it was used minimally. It's not to debunk it, but this is what happens in the real world. Duplex ultrasound, beside telling us about the veins, can tell us about the thickness of the tissue. And this compares a patient on your left with edema of 1.7 millimeters after treatment with compression. The patient's dermal thickness is to 0.7 millimeters. So it gives a very accurate description of the effect of therapy. As I said, there's no simple non-invasive method to evaluate the lymphatics yet. But we've looked at the lymphatics using a different tool than lymphoscintigraphy or lymphangiography, working with the group from University of Texas in Houston, Eva Sevick and John Rasmussen. The use of near-infrared fluorescence imaging, or NIRFLI. This can give you real-time imaging of the superficial lymphatic transport, tells you about the severity of lymphedema, and determines the functionality of the lymphatics. This shows normal architecture. On your left, there is pulsatile flow up the lymphatic vessels, and on your right is seen the same vessels in the thigh. This is a perfectly normal examination. This is an abnormal examination. Like other imaging studies, there's evidence of dermal backflow in a lateral calf, and you can see the arrow at the supramalleolar area pointing to a tortuous lymphatic, which is beaded and enlarged. In addition to giving us architecture, it can look at the lymphangion, which is the heart of the lymphatic network, and can determine how frequently the lymphangion contracts, normally about 0.46. In PHLEBOLYMPHEDEMA studies that we've done shows that there are decreased contractile events so infrequent to be quantified. And so this decreased pumping may be the underlying pathophysiology that we see in these patients with PHLEBOLYMPHEDEMA. As far as therapy, this just shows the Greek god Janus looking at both the venous and lymphatic treatment pathways. We have to deal with both. And these are two linked diseases, but two different treatment processes are required. You have to reduce venous hypertension and reduce edema. As far as reducing venous hypertension, we use the DUPLEX ultrasound and other imaging studies to, thank you. Looks like I got a three-point play. We use the DUPLEX scan to assess the superficial system. On your left, a patient with advanced venous disease, and on the right, an image of a patient who's had stenting. And we then ablate the great saphenous vein and reduce venous hypertension. Stenting relieves the outflow obstruction shown on your right. What about reducing edema? Well, there are several modalities for this. One is manual lymphatic drainage, as shown as on your left. And on your right is sequential pneumatic compression device, both promoting flow of fluid up through the, it's not responding. Can you advance this? Okay. Well, one question is, if you're treating the venous side, does edema resolve with this component alone? And we looked at this in about 8,000 patients who had stenting procedure in about 13%. And basically, after treatment with the venous side with ablation, 87% went on to drop to 40% after manual lymphatic drain or pneumatic compression devices. By contrast, the stent requirements were much low, 13%, and they persisted to a same proportion as did the ablation group. So there are patients that require treatment of their, even though they've had the venous hypertension resolved. Finally, just to go over treatment allocation of these patients with lymphedema, again, from these 27,000 patient cohort, 20% undergo no treatment. The majority of these patients receive conservative therapy, about 65% with MLD, and about 16% require a pneumatic compression device. So we compared breast cancer-related lymphedema to PHLEBOLYMPHEDEMA regarding specific treatment. What we found is the PHLEBOLYMPHEDEMA patients receive less specific lymphedema therapy than breast cancer, 94% to 82%, leading to a treatment gap. And then when you look at the specific treatment modalities comparing breast cancer-related lymphedema to venous-related lymphedema, you see that the conservative treatment mode is used less frequently in the red, the PHLEBOLYMPHEDEMA, as is manual lymphatic drainage. The reverse is seen, however, as far as pneumatic compression devices, where more patients receive pneumatic compression devices with PHLEBOLYMPHEDEMA. So in conclusion, PHLEBOLYMPHEDEMA is the most common cause of lower extremity lymphedema. Compared with breast cancer-related patients, PHLEBOLYMPHEDEMA patients are less likely to receive any specific lymphedema therapy. Conservatives prescribe less, and PCD is more likely to be prescribed. Surgical treatment of the venous component alone is insufficient, and these differences suggest that the role of lymphatics may be undervalued in PHLEBOLYMPHEDEMA. Thank you very much for your attention.
Thanks so much, Dr. O'Connor. Nicely really displayed that overlap. And I would say it's what we see most frequently in our clinic. And it can be a clinical conundrum and very difficult to manage. I think Dr. Singhal is going to start with a question. I have a couple myself.
Great, Dr. Donald. Thank you so much. First, I'm going to just start with a comment and then a question. The comment is yesterday, actually, we had the NIH clinical pre-event. And one of the avenues, one of the areas where the NIH felt we needed more data was not just on anatomy, but function of the lymphatic system. So I think the work you were doing with Dr. Aldrich and the group down in Texas really helps fill that void and is really important. So thank you very much. My question is really about anatomy and this crossover again between the venous system and lymphatic system. We know anatomically they ride right next to each other. And oftentimes we have a question of the chicken or the egg. May Turner's comes in, a stent has been placed and the patient didn't get better. Was this always lymphedema, or was this venous disease that was treated and maybe this spilled over into lymphedema? Do you believe interventions on the venous system could lead to lymphedema, meaning a stent is placed into the venous system and is too large that it actually compresses the adjacent lymphatics, or if you ablate a vein, potentially the heat from that could lead to injury to the adjacent lymphatic system?
Well, that's a very good question. And certainly I can answer, I think it's hypothetically more common with ablation technique that is based on a thermal energy type as opposed to glue or other mechanical means. So yes, because the superficial lymphatics run very close to these, they can develop lymphedema. I've done in my practice over 1,000 thermal ablations. And I must say that the incidence in follow-up of lymphedema associated with that is pretty low, but hypothetically, yes, but practically, no.
Kind of to tag on to what Dr. Singhal was saying, we've had a fair amount of patients, particularly the younger patients that are coming with left-sided lower extremity edema. We get an MR and they have some compression that's modest of their common iliac vein and the May Turner anatomy. How do you go about assessing that? Do you stent it? The Alabama group has shown that does a lot of stenting, that often it can be helpful and it can resolve lymphedema. Are there any kind of tricks you use, either clinically imaging or invasive imaging, to help differentiate how significant that lesion may be?
Well, that, and I'd also want to look at the lymphatics in that particular patient first before jumping into a venous intervention. So here would be a good indication for using lymphoscintigraphy if your institution does it, to make sure that they're normal. And that would encourage me more to treat the patient. I'm not one to encourage stenting of a young patient of the iliac outflow system with pretty moderate stenosis. I know my good friend Raju in Mississippi, who's probably done the most in the world, encourages it, but we're pretty conservative in our institution treating those patients. But I think you have to look at the lymphatics first and make sure that it's venous in origin. Because if you look historically, back in the 50s, they used to think that that compression was causing these patients with lymphedema, why young women at Menike usually have lymphedema of the left leg, and it appears at that time. The hypothesis was it was due to compression, as you stated.
Excellent. Well, I think we'll move on. Thanks so much, Dr. O'Donnell.
Thank you very much for inviting me.